The first case of a child in Australia allowed to undergo sex trait modification came before the Family Court in 2004. This child was apparently being treated by a particular endocrinologist and psychiatrist at the Royal Children's Hospital in Melbourne, where eminent in their field, familiar with the international literature and influenced by the treatment guidelines published by the Worldwide Professional Association of Transgender Health and the US Endocrine Society, and also in communication with doctors working at the UK's Tavistock Clinic. By 2011, the Royal Children's Hospital was supervising the medical treatment of 15 gender dysphoric children. The endocrinologist was retiring, and Dr. Michelle Telfer, a specialist in adolescent medicine, volunteered to take responsibility for their ongoing care. She admits to knowing nothing about this branch of medicine before she started the role. So to prepare herself, she listened to her patients, did a lot of reading, joined the Worldwide Professional Association of Transgender Health and the Australian Professional Association of Transgender Health, went to conferences, and was apparently convinced by what she heard about the benefits of medical affirmation and the disbenefits of non-treatment. The problem for gender-affirming clinicians in Australia was that the Family Court needed to approve their decisions. One case, Reed Jamie 2013, succeeded in persuading the court that the sterilisation of children, which often results from puberty blockers and cross-sex hormones, is an unfortunate side effect of treatment that is necessary and life-saving because it reduces the risk of suicide. Satisfied that puberty blockers are safe and entirely reversible, a claim that has since been challenged, the Family Court allowed that only stage 2 treatments, which is cross-sex hormones, would need court approval, and then only so that the court could be sure that the child was fully capable of understanding what was being proposed, sufficient to provide informed consent. But the numbers of children being treated were rising, and the requirement for court approval for every single case was becoming burdensome. The applications were rarely challenged, and so the court was hearing the same evidence presented again and again. Between 2013 and 2017, 63 court applications for stage 2 treatment were made in Australia, and only one was denied. Kelvin 2017 removed the requirement of court approval of cross-sex hormones, at least in part, because it trusted that the Australian Standards of Care and Treatment Guidelines for Trans and Gender Diverse Children, authored by clinicians at the Melbourne's Royal Children's Hospital Gender Clinic, would ensure robust diagnosis of new patients and good clinical governance sufficient to protect the best interests of children. But there are cogent reasons for believing that the court may have been wrong about this. The court assumed that a robust diagnosis would precede treatment decisions. The Royal Children's Health Guideline mentions a comprehensive multidisciplinary assessment involving specialists from different areas of medicine who are all available to provide advice, but this appears to be used to assess their mental health issues and monitor progress once treatment decisions had already been taken. The informed consent model departs from the conventions of Western medicine, in which treatment is offered to correct a diagnosed problem. Since gender incongruence is not recognized as a problem, diagnosis is not required before clinicians affirm a gender identity. Evidence that a rigorous diagnostic process precedes gender affirmation at the Royal Children's Hospital Clinic is lacking. Further, gender affirmation in Australia isn't confined to gender clinics. The Royal Children's Hospital guideline allows GPs with sufficient expertise and skill in initiating and monitoring hormone therapy to consider initiating and optimizing hormone therapy for suitable GILIC-competent minors. If they don't feel confident to assess the appropriateness of gender-affirming medical treatments, or a patient's readiness to commence these treatments by themselves, or uncertain about the patient's ability to consent to treatment, GPs are advised to refer the patient to a qualified mental health professional with experience in providing gender-affirming care who can support the patient's exploration of their identity, assess their decision-making capacity, and help address any mental health concerns or complexities. Where previous editions of the Royal Children's Health Guidelines suggested that GPs conduct an assessment of the adolescent's gender identity, this has been dropped from the latest version. The Royal Children's Hospital does mention a comprehensive multidisciplinary assessment that is used to monitor progress once treatment decisions have already been taken. The UK's CAS review has emphasised that both diagnosis, which is working out what the problem is, and differential diagnosis, working out what the problem isn't, is required. From the wording of significant judgments, it seems clear that this is in line with what the family court was expecting. The CAS review has also explained that the preconditions for informed consent are not satisfied simply by a child and or their parents agreeing to the treatment. It also requires the patients and their family to have been given a wide range of treatment options with the risks and benefits each clearly explained so that an informed choice can be made. There is no evidence that anything other than medical transition was on offer at the majority of clinics that advocate the gender-affirmative care model. And according to Michelle Telfer, the lead author of the Royal Children's Hospital guidelines, it was written to reflect that what was already happening in Australia because clinicians had gone ahead of the WPATH guidelines, introducing puberty blockers and cross-sex hormones at earlier ages than officially recommended. In a 2020 interview, Michelle Telfer explained that what we did as a team was initially follow the WPATH guidelines and to use those guidelines plus the evidence we had in moving forward from those guidelines. Because as you know, the WPATH guidelines were published in 2011, and whilst they were the most progressive guidelines in 2011, between 2011 and 2018, there was a lot of change. And a lot of evidence that was coming out of that was suggesting chronological age used to decide when someone should start hormone treatment, for example, was not necessarily in the young person's best interest. And we saw the benefits through the data. We needed to actually reflect clinical practice in our guidelines, and in a search around the world, there weren't guidelines that we could say we were following that were evidence-based and reflected best practice. So being Australian, we have that kind of larrikin element where we just go, right, well, we just have to make our own. We'll just do our own. There is good reason to believe that the clinicians pioneering medical sex trait modification for children sincerely have the best intentions for their patients. The question is whether anything more substantial than their own observations, WPATH standards of care, and the professional consensus that prevails amongst gender affirmation advocates justify these interventions. The Royal Children's Hospital now has 1,500 children on its books, and other gender clinics around Australia have experienced a similar rise in demand. What's causing all of this? Is it, as activists believe, because we now recognise the reality of gender identity as important and the climate of acceptance encourages these children to come out and tell us who they really are? Or is it that we are projecting adult identities onto children who are responding to suggestions about cross-sex identification and being taught about non-binary identities in school and online? As well as gender clinics, we have lobbyists like OzPath, Equality Australia, and the AIDS Council of New South Wales, which is funded by the New South Wales government, who all support the affirmative model of care, working with and advising government organisations like the eSafety Commissioner, the Australian Bureau of Statistics, as well as influencing politicians with the aim of changing public policy and passing laws that would allow children to be medicated without parental knowledge or consent. Some states have already passed laws that threaten parents who resist medical gender affirmation for their children with prison sentences, like the Victorian Change or Suppression Conversion Practices Prohibition Act 2021. Gillian Spencer was suspended from working as a child psychiatrist at Queensland's Children's Hospital because she regards gender-affirming care as unethical. In Victoria, clinicians might face criminal charges and custodial sentences for offering forms of therapy that were, until 2 minutes ago, regarded as mainstream. The issue is now much bigger than just the medication of children. It raises questions about whether professionals have the capacity to debate evidence, whether Australians in general are still free to disagree about gender identity, about whether parents still have the right to protect their children from medical interventions where they think these are harmful. Because the issue of gender identity is now colliding with so many different issues, it is vitally important to Australia's future that we are able to openly discuss what has been brought to us in this current cultural moment and whether we want to continue in this direction.